This conference will now be recorded.
Welcome, everybody. In this section, we're going to be discussing Chapter 18, which is going to be altered mental status, stroke, and headache. So first, when we're looking at our readiness and our objectives, this is what we should be discussing and looking over prior to the lecture. So let's start off with our case study. Hurry is back here. Mrs. Hewlett calls the EMTs Fred and Kemp. I think he's having a stroke. They find a 69-year-old male patient sitting in a chair looking anxious. Mr. Hewlett begins to speak, but his speech is slurred and there is a noticeable droop on the right side of his face. So these are classic signs and symptoms that we may see somebody who's experiencing a stroke. So what would make the EMT suspect the patient might be having a stroke? Based on our case study, we found out that patients got a facial droop, so that's an indication. They got slurred speech, and then also anxiety can play into it as well. Other conditions that could explain the patient's presentation. Facial droop and slurred speech is also common in the medical condition called Bell's palsy. And so a stroke basically affects the entire left or right portion of somebody's body. Bell's palsy only affects the facial features. So how should the EMT go about determining what the problem is? Whether this is a diabetic issue, whether this is Bell's palsy, or whether this is stroke or some other type of altered mental status emergency. We simply go through our patient assessment, and then based on our assessment, our medical history, and our vital signs, we can start to create our differential diagnosis utilizing pertinent positives and pertinent negatives. So altered mental status, this is going to be any root cause that's going to cause that patient to be altered in any way, shape, or form. Early recognition of the stroke, when we're discussing stroke and stroke-like care, is the key factor. Very similar to our sudden cardiac arrest is the early identification and the early transport, early recognition, and getting that patient to the chronic care setting, which is going to be the hospital. One thing that we don't discuss very often within the American Heart Association is the prevalence of headaches within patients suffering from strokes. So some patients may not display the classic signs and symptoms as far as right-sided or left-sided weakness, facial droop, but they may complain of the worst headache ever. Take that seriously and mark that as an indication of a patient presenting with stroke-like symptoms. Other altered mental status. So altered mental status can be caused by a variety of different things. It could be an indication of illness and or injury. It could be toxic, metabolic. The brain needs three things in order to survive. It needs sugar, it needs water, it needs oxygen, and then also in the presence of any mind-altering substances such as drugs, such as alcohol. And then also the brain's got to be kept at 98.6 degrees too in order for it to operate properly. So if we're looking at these categories, other causes of altered mental status, we got shock. So we got hypoperfusion, which leads to less blood flow to the brain, which means less oxygen. Drugs that depress the central nervous system. So benzodiazepines, opioids, heroin, street drugs, all of those are going to interact within the central nervous system and cause disturbances on how your patient normally, regularly acts. Post-seizure state, we discussed this, where we have a patient seizing for an extended period of time. They might deplete their sugar stores, they might be hypoxic. Stroke, again, this is all going to be about blood flow and hypoxia. So a stroke, we're going to discuss two key disturbances. One is going to be the ischemic stroke, where we have a blockage. The other is going to be a hemorrhagic stroke, where we actually have a brain bleed. So our assessment-based approach, conduct that size up and start painting a picture in your head. What could be the root cause of this altered mental status based on your environmental findings. Are you responding to a single family residence in right now? So late part of fall, early part of winter, people are starting to turn on their furnaces for the first time. Could this potentially be a carbon monoxide poisoning? Are you responding to a plant? Are you responding to a park where it might be an allergic reaction? Again, you have to create kind of a detective work when you are providing emergency medical care. Look for the mechanism of injury and or nature of illness. Collect the patient's medications, and then in the event that you do suspect a hazardous material from actually invading that patient and creating that altered mental status, if you can do so safely, remove that patient as quickly as, as quickly as you can. Other assessment. Stabilize the spine if indicated and only if indicated. If you come across a patient who is unresponsive and we have no idea how he became unresponsive, that's automatic. We're going to see spine and color that backboard or patient because we do not know if they had any type of indication of trauma. Go through our ABCs and then provide that oxygen therapy if needed. Again, hypoxia is one of the leading causes of our patients to be displaying altered mental status. Our secondary assessment is going to dive into our vital signs, our history, and our physical exam. So vital signs, when we're looking at a patient displaying signs and symptoms of a stroke, generally are going to be elevated, specifically the blood pressure. Hypoglycemic patients, their heart rate and their blood pressure might be slightly elevated, but they're not going to be elevated to the point where we would see a patient with signs and symptoms of a stroke. Very important that we're looking at that physical exam and really getting our hands on our patients and look for environmental clues or trauma-related instances. So possible findings, if we do suspect trauma would be the cause of this altered mental status, look for any decap BTLS. And when I say that, I'm talking about deformities, contusions, abrasions, penetrations, stab wounds, anything like that. Other findings, high or low blood pressure, again, that could be an indication. Unequal pupils, oftentimes we see unequal pupils in patients with a significant head injury. Discoloration around the eyes and behind the ears, that's an indication of a basilar skull fracture. So discoloration around the eyes is going to be referred to as raccoon eyes, and bruising behind the ears is going to be referred to as battle signs. Pale, cool, moist skin, we all know this based on our shock findings. If a patient is in trouble and they're going in a shock or hypoperfusing, they're going to shunt that blood away from their skin, and as a result, they're going to become pale, cool, and diaphoretic. So that's a significant finding. Any patient that's displaying signs and symptoms of shock, make sure that we're keeping that patient warm. And then decorticate or decerebrate posturing, that's a significant finding for head injury and central nervous system injuries. Now, if we're starting to steer down the route that most likely this is medically related, look for any of those abnormal vital signs. Look to see if that skin condition has changed. Maybe it's an environmental factor that's caused this altered mental status. Too hot, too cold. Pupils are a dead giveaway in opioid-based overdoses. So if they're pinpoint, chances are that it's going to be drug related. If they're unequal, that's going to be trauma related, and or some patients have a disposition to always have an unequal pupils. If they're blown, if they're extremely dilated, that's another indication that there might be some drugs on board. Make sure that we're getting that last vital assessment, checking for that high or low blood sugar. So normal patients, roughly 80 to 100, 80 to 120. They're significantly high, they're significantly low. That's where we can see that change in that mental status. So when we're providing our emergency medical care for a patient with altered mental status, this is what we're going to be going through. We arrive on scene, we identify the need for C-spine precautions immediately. If we do find that need, direct somebody to immediately maintain C-spine control. Then airway, breathing, circulation. And when I say ABC, we're thinking these steps of ABC, but once we get proficient and good as EMS providers, we should be able to do those three things all at the same time. So I'm checking for a pulse, I'm looking at his chest rise and fall, and I'm listening to see if I have any abnormal airway sounds. Ventilate if needed, anytime respiratory system is compromised, and or oxygenation if it's less than 94. Position that patient in a position of comfort, or depending on the interventions that you're going to do. So let's say you're providing aggressive airway treatment. We're going to be in the supine position. If that patient is violently vomiting, they're going to be in the left or right lateral recumbent position, and then get that patient ready for transport. Any patient displaying an altered mental status is going to be considered a critical patient, and that's why we reassess every 5 minutes. So for our non-critical, the textbook is going to tell us that we can reassess every 15 minutes. But I don't know what the hell you're going to be doing for 15 minutes, just sitting there staring at them. Reassess your patient regardless, critical, non-critical, every 5 minutes. And then look for any improvements and or deterioration within our vital signs, within our mental status, and then look for trends within your vital signs. When we are going through our patient history, patients who have had previous strokes can still have strokes in the future. And so there might be patients out there who have a neurological deficit when you are going through your patient assessment. So it's very important when we're diving into our patient history that we're asking the significant other or the patient, if they can answer properly, what is your normal baseline? Do you always have right-sided weakness, or is this a new onset for you? Acute stroke, so remember our medical terminology, we have acute or we have chronic. Acute is going to be short or a rapid onset. Chronic is going to be longer and or extended. So acute stroke, we only have a certain amount of time in order to recognize that and get that patient to the hospital, because they may need surgery in order to fix that burst blood vessel, or fibrinolytic therapy in order to remove that blockage and start to get the brain perfusing again. So the AHA says act fast, and that is looking for facial droop, looking for slurred speech, and then also weakness on one side of the body. When they're providing medication therapy for stroke patients, there's only a certain time window that you can actually give that medication. So it's very important as EMS providers that we find out the specific onset of those signs and symptoms when that patient started presenting that stroke, and make sure that we're radioing our report to the hospital as soon as we can. St. Mary's Hospital, this is Cloquet Medic 9. We have a 54-year-old male patient, stroke alert. Onset of time was 5:30 in the afternoon. So our pathophysiology, I mentioned already that we have two different types of strokes. We have ischemic strokes and or hemorrhagic strokes. So ischemic strokes are very similar to our heart attack patients, where they have a blockage within one of the blood vessels, and as a result, we don't get blood supply to a specific portion of the brain. As a result of that lack of oxygen, that portion of the brain begins to die. Now, for our patients who have a hemorrhagic stroke is a blood vessel that actually bursts. So very similar, the blood supply is not getting to certain portions of the brain. As a result of that lack of oxygen, the cells die, the muscles die, the tissue dies, and that patient displays that altered mental status. So here we can see the difference. We got the brain bleed on the left-hand side. We have a subarachnoid hemorrhage or an intercerebral hemorrhage, depending on where that bleed is on the lining. And then we have our blockages on the right. So most of the time it's going to be plaque, cholesterol buildup within one of the blood vessels, and it hinders the ability for the red blood cells to actually get past that blockage. And remember, the red blood cells are the ones that carry that oxygen. The black deterioration on this patient's brain is the damage that's causing from that ischemic stroke with that no blood flow, no red blood cells, and as a result, no oxygen. So test yourself. Best statement that describes a thrombotic stroke. So an artery in the brain ruptures causing bleeding. No, that's a hemorrhagic stroke. A blood clot forms in the left side of the heart, travels through the arterial system into the brain, causing an obstruction to blood flow. An artery on the surface of the brain ruptures. Okay, that's a hemorrhagic stroke again. A blood clot forms at the site of a damaged artery within the brain, causing an obstruction to blood flow. That is the correct answer. Types of stroke. Again, blockage and/or hemorrhagic. We're not very concerned about the different types of stroke. We're concerned about an individual that's displaying signs and symptoms of that. And that's why it's very important that we never give a patient who's got stroke-like symptoms aspirin, because we cannot differentiate in the field. As discussed, fibrinolytic drugs, they do work very well, but we have a short window to actually give that medication to that patient. So some of our risk factors for ischemic strokes are patients who have cardiac dysrhythmias, specifically AFib, has a tendency to throw clots within the body. Hemorrhagic stroke, some of our risk factors, nicotine usage, heavy drinkers, high blood pressure, diabetic patients, all run the heavier risk of hemorrhagic strokes. So ischemic strokes, commonly the signs and symptoms are going to be the atypical signs and symptoms where we have one-sided paralysis, facial droop, slurred speech, altered mental status. Hemorrhagic stroke oftentimes falls within that severe headache category and also could be complaining of nausea and vomiting with an altered level of consciousness. So we can see this patient, they have the classic signs of that right-sided facial droop, and it looks like this is a predisposition. So this patient has already had a stroke. So this patient could still have a stroke that's going to affect that certain hemisphere of that brain. So you arrive on scene, go through your patient assessment, and what we're going to be doing is the Cincinnati stroke scale. So have them say a common sentence and look for the slurred speech. I can see visually that this patient has facial droop. Have that patient close their eyes, and I'm going to extend their arms straight out in front of them. And I'm going to say, hold your hands up. If it is a right-sided stroke and it's affecting that right-sided extremity area, that right arm is going to drop. And then check CMS. So I'm going to check pulse, I'm going to check motor movement, I'm going to check sensation on all four extremities. So there is a phenomenon called a TIA, and this is a transient ischemic attack. So this is going to display the same signs and symptoms of a stroke. However, the symptoms disappear usually within 1 hour. And this is kind of a warning or a hallmark sign that this patient is going to be very susceptible to full-blown strokes later on. So take TIAs very seriously. That patient's going to need to go to the hospital regardless, because maybe there's some preventative care as far as getting that patient to better their lifestyle and then prevent a future stroke. And there we can see that 10 to 20% risk of a stroke in the subsequent 90 days. So half of these happen within 24 to 48 hours. So this patient, once they come out of those signs and symptoms, I mean, they're going to have the right to refuse, because they're now going to be alert and oriented, and their vital signs are probably going to check out. However, this is where your medical expertise really comes into play with the public, and recommend that they go get seen because of these warning signs that they're displaying. So there is also called a cryptogenic stroke, and it can't be attributed to a specific cause. So nobody's perfect within the medical world. We're still understanding and discussing and researching new things on a daily basis. And this is just one of those things that we know what's out there, but we don't know what the cause is. So our assessment, we have somebody displaying stroke-like symptoms. Conduct our scene size up, determine that nature of problem, and note exactly when the patient was found or when the last time that they were found normal so that you can document that time. Go through your ABCs, assess and intervene as necessary for any immediate life threats with our ABCs, major bleeds. And then with our secondary assessment, pay close attention to that central nervous system and dive into the Cincinnati stroke scale. And then significant findings are going to be that facial droop, that one-sided weakness and or paralysis, slurred speech, altered mental status. So the Cincinnati stroke scale is not the only one that you can do. There's a variety of different ones and they're going to outlay in your book. Go ahead and take the one that you like and utilize that one. As far as stroke centers go, two different types. I'm not 100% sure what the different types of stroke centers are, but there's going to be stroke centers that are going to be providing hemorrhagic and ischemic care. There's going to be other stroke centers that only can provide the fibrinolytic care. St. Mary's and St. Luke's both provide both types of care. Secondary assessment, we're going to obtain our sample history, so signs and symptoms, allergies, medications, past pertinent history, last oral intake, events leading up to. Remember, our signs and symptoms also correlate with our OPQRST. So onset, when did your signs and symptoms first start to appear? Provocation, does anything make it feel better? Does anything make it feel worse? Radiation, does your signs and symptoms go anywhere? Severity, 0 to 10 scale, 0 being no pain, 10 being the worst pain possible. Can you rate it? And be careful with that because these patients might not be displaying signs and symptoms of pain. And then time. And when we say time, we already talked about onset, but time can also be consistency. Do these signs and symptoms come and go? Are they constant? Then within our secondary assessment, they used to teach us back when about providing oxygen therapy to basically anybody displaying stroke-like symptoms, even if their SATs are 94% or above. Only provide oxygen therapy for stroke-like patients with oxygen saturation levels less than 94% because we do release free radicals into the body and those attack and create tissue damage. So really take this picture into mind. Which patient looks normal? Which patient looks abnormal? So the patient on the right, another thing that we can do in order to test for facial droop is have that patient smile big and show their teeth. And we can see that's what's going on right now is that patient's attempting to smile, but the right side of her face is the only side that's actually conveying up. There we have the arm drift test. Patient close their eyes, extend their arms, and see if they can keep their arms extended all the way out. So signs and symptoms are Cincinnati. We got facial droop, we got arm drift, we got abnormal speech. If they meet any of these criteria, you're going to go ahead and call that stroke alert. Here we have the Los Angeles pre-hospital stroke screen. I'm not going to dive too deep because I am much more comfortable with the Cincinnati one. If you want to read up on the Los Angeles one, go ahead. Generally, and when we're looking at National Registry test questions, the AHA, a lot of it focuses simply on the Cincinnati stroke scale. So our emergency care, we're maintaining perfusion, and all we can really do is drive like hell and get that patient to the hospital as quickly and as safely as we can And be careful because these patients can go into cardiac arrest on us very quickly. So have your suction ready, have your AED ready, have your airway management equipment ready to facilitate. That patient is unresponsive, they do have the tendency to be nauseous and or vomiting, so you can position that patient in a left or right lateral recumbent position if we don't suspect any type of C-spine injury. Patients alert, go ahead and position themselves in a position of comfort. Generally, it's going to be that semi-Fowler's position. Very important that we're checking the blood glucose levels on this patient because it could be hypoglycemic related. So if it's hypoglycemic related, it means their blood sugar is extremely low, and go ahead and treat that blood sugar. So headaches, not something that we're called to extremely often when it's simply a headache, but if it's the worst headache in their life, again, that could be signs and symptoms that it might be a stroke related. So we have different types of headaches. We have vascular headaches. So this could be led from migraines or hypertension. So migraines is that medical diagnosis that a lot of individuals who get bad headaches and on a consistent basis, they're going to be diagnosed with having migraines. Hypertension, so high blood pressure, that could also lead to individuals having headaches. Oftentimes they describe it as an ache or a pain behind their eyes. Then we also have cluster headaches, tension headaches, and inflammatory or organic headaches. So suspect any type of serious underlying issue if they're displaying an altered mental status, if they can't see properly or hear properly, if there's a bizarre behavior change and or a seizure. Because we learned that there could be a brain infection that leads to a seizure and that could also cause that headache too. So our assessment, based on these findings, this could underline a significant finding. If it's an abrupt onset, again, that's an indication that it might be a stroke. If it's worsening of pain with coughing, sneezing, or bending over, that's an indication that there's an inflammation within the brain tissue going on. If there's a fever or a stiff neck, this could be an indication that it's meningitis and there's an inflammation from a bacterial or virus infection within the brain lining, and or there's a change in the quality of that chronic headache. So maybe they're complaining of a dull ache and now it's a sharp ache. Something along those lines where that quality is differentiated. Our care, if that patient wants to go to the hospital, and they should, especially if it's a significant headache, go through our steps, maintain perfusion, and transport rapidly. So our case study conclusion. Because of Mr. Hewlett's slurred speech, both EMTs are immediately aware of the potential for airway compromise. Fred carefully assesses the airway and breathing and asks Mrs. Hewlett what happened. Mr. Hewlett is alert and he's frustrated at his difficulty in making himself understood. Fred assures him that he will quickly do what they need to do and get him to the hospital for further assessment. Fred's stroke scale assessment confirms the facial droop and difficulty speaking, reveals a slight weakness of Mr. Hewlett's left hand. Mr. Hewlett is able to maintain a sitting position, and so they transport them into a semi-Fowler's position. Reese was able to obtain information from Mrs. Hewlett, including the time of onset signs and symptoms, which the EMTs know will be important in determining their ongoing treatment and assessment within that care. So based on the Cincinnati stroke scale, he displayed signs and symptoms of facial droop, slurred speech, and weakness on an extremity. So he met the criteria. This is going to be a stroke alert at this point. So let's go through the summary. Altered mental status can be caused by a variety of different things. Remember, we have sugar, water, and oxygen that need the brain in order to survive. If one of those things is hindered, or we have a significant mechanism of injury, or we have an outside substance that's hindering the central nervous system, those can cause that altered mental status. Strokes can be ischemic, they can be hemorrhagic. So from a blockage or a brain bleed, are we majorly concerned between the two? No, we're concerned about whether that patient's displaying signs and symptoms, rapid transport, rapid recognition, notifying that patient that, or that hospital that we're coming in with a stroke alert. Also, very important with our stroke patients that we are documenting and relaying the time as far as when signs and symptoms started. Headaches can cause a significant or be caused by a significant underlying medical issue. Do not take those with a grain of salt. And we were correct. It was a thrombotic stroke caused from a blockage. That concludes our stroke-like symptoms and our altered mental status, which is chapter 18. Thanks, everybody.